موجودة، فخير خلف لخير سلف أكيد يعني.
Thank you so much وميرسي على to the chairperson. So thank you so much for the very nice introduction and to all attendants. Thanks to Professor Emad Ebied, Professor Ilham Yusri for all this effort that has been done. Today I'm going to talk about something I believe, if possible, I wanted to be interactive as much as we can. And if you have, because we face a lot of cases with multiple drug resistance in our neutropenic patients. So I'm just going to give an example for one of the patients that has been treated. And I'm going to say the approach and what are the guidelines. And so I believe we have my dear Professor Dr. Dalia. Are you here, Dr. Professor? Dr. Dalia? Dr. Dalia is a professor of clinical pathology microbiology at the NCI. She's going to participate with me. She's going to participate with me the cases and the biogram for infection at the NCI in particular and in Egypt in general. So we are talking about the local epidemiology. So the local epidemiology is extremely important about the organism. So maybe the organism encountered in Egypt is quite different than the organism encountered in other European or American or other countries, Western countries. So Dr. Dalia is going to help me during my very small presentation about the diagram of the organism encountered at the NCI and in Egypt. So I'm going to talk about the multiple drug resistance in organism. I'm going to start by case number 1. He is a 19-year-old male. He was diagnosed to have acute lymphoblastic leukemia, and he was receiving a protocol for acute leukemia. And he was a good responder to chemotherapy, and he received intensive chemotherapy during the maintenance chemotherapy. He developed myelosuppression as usual. And this patient, he stayed for 5 days at home, febrile. And he didn't come to the hospital. He didn't do a blood count. He didn't follow the instructions and the guidelines that we follow. He had the respiratory distress. He came with the respiratory distress with cough and dyspnea, as you can see, diarrhea. On examination, the patient was conscious, dehydrated, febrile, temperature above 38.5. He was a hypotensive. He was tachycardic. Respiratory rate was around 30. Saturation with the 15 liters was about 80%, 75 to 80. So this patient, he came delayed to the hospital, and he was febrile for 5 days, and he is expected to have been neutropenic. So this patient is required to proceed for rapid intravenous antibiotics from day 1, not from day 5. So this is what happened, and as we know that this sometimes happens. So on examination, he had the coarse crepitations. He has tenderness on the epigastrium. His liver was around 5 centimeters, and maybe it was congested liver. So the blood count, he was neutropenic as usual, leukopenic, and anemic and thrombocytopenic. CRP was more than 150. Creat was elevated. And I repeat, creat was elevated. And please, if you want to be interactive, I'm ready to cooperate with anybody. His bilirubin was a little bit elevated. It was more than 3.5, and he was hypoalbuminemic. So the patient, he was admitted, arterial blood gases, room air showed carbon dioxide 37, the pH was 7.3, oxygen saturation 89%. Chest X-ray was done as the patient general condition could not allow to take him to do a CT chest. I'm just going to show you the first chest X-ray. We couldn't have done CT chest, and this was his chest X-ray as a matter of fact. As you can see, you can find infiltration and pneumonia or denoting there is significant pneumonia, whether it's bacterial or fungal. Whether it was bacterial or fungal, we really don't know, but this is a very simple chest X-ray. So the patient was resuscitated, normal saline. His blood pressure was still low in spite of adding fluids. Echo showed 30 to 40% ejection fraction. Abdominal ultrasound, he showed typhlitis. So right now I'm having a patient, he came to me after intensive chemotherapy for a case of hematological malignancy. He came to me with the suspicious typhlitis. He came to me with leukopenia. He came to me with significant hypotension. I'm having a lot of manifestations. So he started. So I want to know from your point of view, how to approach such a patient. Patient hemodynamically unstable. Patient is hypotensive. Patient suspicious typhlitis by abdominal ultrasound. Ejection fraction is poor. Patient leukopenic. Chest X-ray shows infection. He was kept at home for 5 days. And I just repeat, he was kept at home for 5 days without intervention, neither intravenous nor even oral antibiotics. So what do you think? Should we consider broad spectrum plus antifungal, MDR, surgical approach? What do you think? I'm going to tell you the opinion from the medical point of view, not my opinion, the guidelines opinion, and I'm going to tell you what happened to the patient. And we are going to manage. He was empirical. He started intravenous meropenem, and it was adjusted to the renal dose. And I repeat, he started intravenous meropenem, adjusted to the renal dose, ciprofloxacin, and he started linezolid due to impaired kidney function. As just a gentle reminder, his kidney functions were 2.6. So should we do a renal adjustment in a patient with a septic shock? What's your opinion? What's your opinion, Dr. Ahmed? Should we do a renal adjustment for a patient with septic shock or not? The patient came to with the renal adjustment, impaired creatinine. This was an element of debate. Shall we proceed for renal adjustment? That I mean, I'm going to give him intravenous meropenem, for example, once per day, according to his renal impairment, or shall I proceed for the regular dose? I just wanted to get you one of the article was published and saying that they do not recommend if the patient has a normal kidney functions, but he came to me with an impaired kidney function. These are not the guidelines, but it was published in 3 very, very important articles denoting that for this patient, if he has always a normal kidney functions and he just came to me right now, you may not start antibiotics according to his renal impairment. You may start the full dose of antibiotics. So they should be put into consideration. These are not guidelines, and I'm going to repeat. And if you have any discussion, I'm ready to open it for any discussion. But we're just talking about how to approach such a patient. So you may give the patient full dose of intravenous antibiotics, and they may not change the antibiotics according to the and I'm going to send you another. Another paper was published saying that you should not do modification in the beta-lactams. That means meropenem and cephalosporins. So you may give the full dose for the 3rd, 4th generation of cephalosporins, or even the 5th generation of cephalosporins that's appearing right now in the market. So the patient condition deteriorated, and he was intubated, and he was ventilated, and he had respiratory distress grade 3. The repeated chest X-ray after intubation showed worsening consolidation in both lungs. This is the chest X-ray, as you can see, marked deterioration. He started on meropenem, ciprofloxacin, and he started on linezolid. Thereafter, the CT chest started to stabilize, and the patient revealed CT chest was done and showed ground glass opacities on both. And he started, of course, empirical antifungal therapy. And this is the CT chest findings. I just wanted to let you know the CT chest findings. This is the first film. Another one. I couldn't see anything denoting fungal pneumonia of aspergillosis in origin, mostly. Of course, I cannot confirm, but just want to show you this. This is the third film. So the patient started to have, after that, further deterioration, persistent fever, and worsening of all septic parameters, severe metabolic acidosis. He was oliguric, refractory hypotension, despite maximum dose of inotropics. So this is, we are talking about terminally ill patient due to septic shock. Serial blood culture were done and all were negative. CD COVID-19 PCR swab was negative. We were trying to exclude, as you can see. It can go sometimes with the COVID, but it was proved to be negative. So this patient did a tracheal aspiration, and it was positive for multiple drug resistance. It was C-RAB, as you can know, carbapenase-resistant Acinetobacter, and with a moderate sensitivity to tetracycline, the MDR Acinetobacter was tested for and showed to resistant to the cephalosporins, fluoroquinolones, and carbapenem. And colistin was added, and ciprofloxacin, linezolid were stopped. So I just wanted to say, for this example of patient, just if you are talking at the patient having an MDR, so, and it proved to be carbapenem resistant and cephalosporin resistant, are we justified to stop the carbapenem? Of course not. So what can we do? I'm going to face, I'm having a culture saying the carbapenem resistant. So what do you think? Shall we approach for this? And he's already on meropenem. Shall we change the line? What shall we proceed for? What do you think? Does anybody would like to interact with me and tell me his own opinion? Okay, I'm going to tell you the opinion, not from my own opinion, from the opinion from the guidelines and international guidelines point of view. Of course, and I'm going to answer this question and talk about it. If you have a patient, we are talking about a neutropenic patient. Dr. Yusuf, عاوز تعلق? If you have a patient and he is neutropenic and septic shock like this, we cannot stop the meropenem, we cannot stop carbapenem, but you may increase the dose. As you increase the dose and reach to the maximum level and prolonged infusion over 3 hours. So you should have in the guidelines reaching the level of 8. So if you're going for the conventional dose, you may increase the dose to the high dose of carbapenem, but you may not, and you're not allowed to stop the carbapenem. We have the culture. It proved to be by tracheal aspiration that it was positive for MDR. It was positive for the C-RAB, carbapenase resistant Acinetobacter. تفضل Dr. Ahmed. No, if you have an MIC, high MIC, Dr. Ahmed opened a new subject. Of course, if we did and the patient was going on the regular dose, you proceed for the high dose carbapenem. But if you are going already on the high dose and the MIC is reached 8, so you may stop it. Maybe it's not beneficial, but if you are talking and you proceed for other drugs, I will mention about them right now, and Dr. Dalia will help me in this. It will help us, but from my own point of view, I may not stop it. Maybe I wouldn't have, maybe I don't have the guts to stop it. But I will tell you, if it is totally resistant, you may stop it and you may add other drugs, as we were talking about. Dr. Deliash is going to give us a very brief about the MDR in Egypt, the NCI, because we are facing a problem nowadays, increase the incidence of multiple drug resistance in our patients.
I would like first to thank the professors who allowed me here today, and especially Dr. Emad Ebied. It's a great honor. This case is really challenging, but all our National Cancer Institute cases are such challenging cases. As you all know, MDR is a microorganism that is resistant to at least one antibiotic of 3 different groups of antibiotics. MDR in National Cancer Institute, unfortunately, with XDR, has reached a higher percentage than normal. Being a tertiary hospital, we usually receive the patient after being admitted to multiple hospitals and acquiring organisms from these hospitals. Our patients is under heavy chemotherapy due to treatment protocols, so they are severely immunosuppressed. Multi-organism infections are common. They underwent, most of them has at some time in their lives during hospitalization has undergone surgery or catheterization or whatever, which introduced them to multi-organism affection. This case of CRAP, as we call it, carbapenem-resistant Acinetobacter, which is one of our worst nightmares at the lab. Internationally, it was said that we combine 2 of the following: polymyxine aminoglycozoid, or tigecycline, promyxine aminoglycozoid, tigecycline sulbactam. If meropenem is less than 8, we consider carbapenem with a higher dose and extended infusion combination therapy. Unfortunately, at the NCI, we do not have the same protocol due to our antibiogram results. We usually go for colistin, amikacin, or tigecycline, or a combination of fosfomycin and meropenem as a carbapenem antibiotic, but we go for a high dose of meropenem. At first, like Dr. Emad did, we usually go for caspofungin, but once the culture of fungus is negative, we usually stop it. Broad spectrum antibiotic is not encouraged in such a case. This is here the pediatric ICU bacteria prevalence. As you see, we have around 68% gram-negative bacteria. Acinetobacter gives a rate of 8%. We mostly have E. coli and Enterobacter, and both of them, unfortunately, are ESBL. Surgical ICU bacteria prevalence here is also Klebsiella and E. coli with an Acinetobacter of 6%. Antibiogram of in surgical ICU, we have the highest rate of sensitivity is colistin, and the lowest rate is carbapenem, with an intermediate rate of amikane. In adult oncology ICU bacterial prevalence, we have also the Klebsiella and E. coli of ESBL modification, with Acinetobacter of 11%, which is the highest in adult oncology unit. Antibacterial biogram showed the tigecycline was not percentually available, but out of 20 patients, 17% of them were sensitive, which is a good result. Unfortunately, carbapenems were also resistant. Colistin showed moderate activity, which is good activity. So we go for colistin. Other than that, the carbapenems are cephalosporins are resistant on all three ICU units. The rate of infection by MDR is in the NCI as a whole is between 22 and 30%, which reaches up to 66% in ICU unit due to the fatality of the cases. Thank you.
Thank you so much. I just want to say that just a simple question, Professor Delia. Is this 30% MDR or 20-something is high compared to?
Yes, compared to other hospitals, this is a high percentage.
I mean, in the Western countries, it's considered a high?
I'm sorry?
In Western countries and according
No, it's very low in Western countries. It does not reach more than 6 to 8%, the MDR. Okay. And now we usually combine MDR and XDR together because there is a very limited differentiation between them at the National Cancer Institute. And this is why at the NCI units, it is high percentage.
Okay, just wanted to, this is the diagram in Egypt. So I just wanted to say that I'm talking about this patient in particular. So this patient, he had hemodynamically unstable. I usually go for a single agent antibiotic. And as Dr. Ilham was just mentioning right now, these are the guidelines. We shouldn't proceed for 2 or 3 antibiotics. But for this patient, hemodynamically unstable, he came to me in a very poor situation. He was febrile at home for 5 days. We couldn't do a CT chest. We didn't do a culture. A lot of things were not done. I would go for a very aggressive approach for this patient. So this patient, we are talking in particular about this patient. And we are talking about MDR because there's a new era for the MDR and we should be put into consideration in some patients, not in all patients. So the patient was continued on day 6, as we have seen, the meropenem, extended infusion over 3 hours, and 5 days and 5 caspofungin, and 3 days of colistin. All doses were adjusted to the renal functions, although what my opinion is that you can give the patient full dose. The condition showed further deterioration, unstable arterial blood gases, and then arterial blood pressure and worsening cardiac ejection fraction reaching less than 30%, and there was a rising CRP, elevated bilirubin, severe metabolic acidosis. So should we add more antibiotic for carbapenemase resistant Acinetobacter? What's your opinion? Of course, if you go for the ECMID guidelines that was published 2 or 3 months ago, and I'm going to mention, I know it's not going to be clear, it was just mentioned recently and published recently, 3 months ago. These are the guidelines. So I'm just going to mention these guidelines. We can go for, these are the guidelines by the ECMID, the year 2022, 3 months ago, that we may proceed for a lot of things. First of all, you can add polymyxin or colistin to high dose tigecycline to high dose carbapenem. So you can give carbapenem, you can give for this patient colistin, and you may give him tigecycline for this patient. You may add aminoglycoside, polymyxin, and tigecycline. This may answer your question, Dr. Ahmed. يعني العيان ده لو هو عندي كاربابينم ريزيستنت وانا ماشي على الهاي دوز، انا عندي اوبشن ان انا اديله امينو جلايكوزايد بلس تيجاسايكلين بلس كوليستين. لو انا العيان ده ماشي على ريجولار دوز كنت اوف كاربابينم، ارفع دوز الكاربابينم and I may add colistin. This is very important. وبعدين الكاربابينم لازم اتفقنا ان هي توصل للهاي دوز انفيوجن واوفر ان هي بتتاخد over 3 hours وهاي دوز واكستندد infusion. I'm going to have some answer to these questions and I mentioned them here. This is the guidelines that was mentioned some months ago, as I mentioned before. These are new drugs, ceftazidime avibactam and the ceftazidime tazobactam. These are new drugs that we can do and we can manage in the era of the multiple drug resistance, but not in the CRAB or KRAB. It's not in the CRAB. The patient may benefit in other, like for example, other manifestations I'm going to mention about it right now. other culture that I'm going to mention about right now. So now we're having at the NCI and in Egypt, and NCI in particular, in Egypt in general, high incidence of MDR. So, and this patient came to me hemodynamically unstable. So all this should be put into consideration. So these are the IDSA guidelines, not the ECMED. These are the IDSA guidelines saying the same. You may give for such as KRAB or CRAB. We may give high dose extended infusion of meropenem. We can add polymyxin, and the third agent is not suggested. They may not suggest a third agent of anticycline. And saying in another that we may give monotherapy for TRAP and if the patient for one agent, but colistin is suggested to be added to carbapenem. In the same by the IDSA or the ITSA guidelines is talking about tetracyclines or tigacycline may be given. High dose tigacycline can be given. If the patient has a pneumonia, you may give high dose tigacycline. Other than that, carbapenem and colistin. But if the patient has pneumonia like this patient, so this patient could receive carbapenem high dose, could receive colistin, could receive also tigacycline according to CT chest finding, culture findings. If the patient has no CT chest findings, we may proceed for colistin, and no need, if there has no CT chest findings, for colistin and carbapenem. If he has CT chest findings, you may proceed for the 3 or. If the patient has resistant, as Dr. Ahmed was mentioned, and confirmed, and I'm using high dose carbapenem, we may proceed thereafter for colistin, tigacycline, and amikacin. If anybody wants to discuss, I'm ready. So this is the chest X-ray. You can see deterioration. The patient, he has blood culture finery was withdrawn on day 4, Acinetobacter MDR from the blood and from the trachea, and moderate sensitivity to tigacycline, which was already added, but maybe he was added a little bit. So this patient came late, and as we said before, he shouldn't have came late. And as we said before, I believe we should have started anti-MDR day 1. We should have started carbapenem day 1. We should have started amikacin day 1, as we said. For this patient, I'm talking about this patient. I'm just, these are the different approaches for MDR. I just wanted to enumerate them. Of course, you will not be able to read them. But if you go for Klebsiella pneumonia carbapenase, we may use the new drug ceftazidime avibactam. You may use also colistin or tigacycline. So if I'm having a patient with Klebsiella pneumonia carbapenase, we may use, as we said, this is very important. If you have a patient with KBCs or KPCs, we may use, as we mentioned, colistin, tigacycline, and ceftazidime avibactam. If the patient is VRA, which is vancomycin resistant enterococcus, we may add linezolid. The patient, for example, I am talking about patients with MDR, which is new era, and as Dr. Dalia mentioned, its number of patients is increasing nowadays, especially at the ICU. If the patient had extended spectrum beta-lactamase, we may proceed, of course, for carbapenem, and we may proceed for preferably ESBL carbapenem or high-dose carbapenem, ESBL, and this was mentioned here in the ECMED, the year 2022. If the patient has, for example, CRPA, carbapenase resistant Pseudomonas, we have the opportunity of the 2 new drugs, ceftazidime avibactam or cefotelozone tazobactam, which are available in the market وموجودين عند حضرتك. These are available, but this is not the first approach. This is not the first choice. This should be kept in certain situations. And these are the rest of the guidelines. In patients with, as you can see here, in patients who have carbapenase resistant okay. ده الأولاني مش كده؟ Thank you. I'm going to start case number 2. I'm just doing everything on time. The second patient is a case that I would mention very shortly. I'm going to talk about the case of acute lymphoblastic acute myeloid leukemia. The patient age was 12 years old. She was treated this one was treated at the NCI, and certain treatment started according to the acute myeloid leukemia protocol. The patient has extraocular scleroma. So what do you think about the risk group? This patient is for high risk to develop fungal infection or not? Yes, of course, this patient is high risk to develop fungal infection. What is the definition of developing risk of developing fungal infection? What is the definition? So that means that the risk is more than 10%. So this patient has a risk of more than 10% to develop fungal infection. This is the way we start the antifungal at any. This is the empirical. If the patient still is febrile on day after 96 hours, this is the empirical. Or sometimes we wait till the patient is diagnosed and we have a great possibility by radiography or by to confirm. And sometimes we do treat the patient if we have the treatment established. So we start either prophylactic, preemptive, or we start according to established. So according, these are the guidelines of the ESL and the IDSA and the International Fever Neutropenia guidelines. So the acute myeloid leukemia and recurrent leukemia and allo-BMT are considered high risk for developing fungal infection. So these patients should start prophylactic, as we mentioned before. And if you go for the same, this is the epidemiology, which was published at the IDSA some months ago. These are the risks. So this patient is a high risk patient to develop fungal infection. So we should start prophylactic antifungal for this patient. And this everybody knows. And he's expecting to have neutropenia for more than 3 weeks. So they should be initiated, yes. What to consider? These are the SL from 4 to 8. The risk of more than 10% antifungal should be fungal infection is will happen. So this is be started at once. And these are the 4 acute lymphoblastic leukemia you may give it, or high risk acute leukemia in relapse, or acute myeloblastic, or of course in allo-BMT, we should consider all these prophylactic antifungal. So if you go for the NCCN guidelines, it differs for the drugs given. Just saying that you may give in the acute lymphoblastic fluconazole and acute myeloid posaconazole, voriconazole, or amphotericin, liposomal amphotericin. So this is quite different than different groups. So the NCCN is not recommending for the ALL other than fluconazole for high-risk patients. So if having a patient fluconazole, ALL, you may give fluconazole. These are the COG, which is more concerned with the pediatric age group, and they're not recommending posaconazole below the age of 13 years, and they're recommending, as everybody knows, the voriconazole more than the posaconazole, and they're recommending the caspofungin may be given as a prophylactic for those patients. The patient started prophylactic voriconazole at a dose of 9 milligrams per kg. After 2 courses of an induction, the patient still has fever neutropenia, and CT chest was done. He was febrile, and he has fungal nodule. Are we justified to stop the antifungal or change? What's your opinion? Does anybody want to ask or interact or something? تفضلي تقول سماح. You would like to change the antifungal? Okay, my dear Professor Samah, she thinks that and she's advising to proceed for another antifungal after doing further investigations. So as a matter of fact, I will tell you the guidelines, and as a matter of fact, I totally agree if the patient is deteriorating. But if it was discovered, we may change it according to, I'm totally agree that we may proceed for investigations and we may try to proceed for diagnostic tools. Although, for example, this patient is 12 years old, this female, she's 12 years old, and the COG is not recommending, for example, galactomannan. The COG is not recommending beta-2-glucan. The COG is not recommending culture denoting. So for the pediatric age group, we're talking about different guidelines than the SL or the ITSA or the ECMED, which are recommending these. So you may proceed for changing another line, but this CT chest denotes it's mostly aspergillosis. It's mostly related to aspergillosis. So as a matter of fact, this patient continued on the same line. I think if the patient has a very good and stable general condition, you may continue on the same line of antifungal. If the patient is deteriorating, in all circumstances, you may proceed for further investigations. So the patient, as a matter, this is what I asked, shall we shift to another line, antifungal, proceed for a biopsy, or continue for a occlusion? Professor Samah was suggesting to proceed for another antifungal. This patient continued on the same line, I believe. And these are the guidelines. And if you go for the empirical, as the one I'm highlighting here down, that we may switch to a different class of mold-active antifungal. We may do this. And we have a lot of lines. I would, by changing the line of treatment, can be considered. If the patient is stable, and all the investigation proved to be as it is, no deterioration, you can proceed on the same line with a very close follow-up of this CT chest. A very close follow-up for this CT chest. So just back, these are the guidelines for the SL6 guidelines. It recommends voriconazole as the first line, isavuconazole as the first line, line number recommendation A1, then liposomal amphotericin B, and caspofungin can be considered, but it is considered to be recommendation C2. The combination, we have a lot of comments on the combination. That's why if you have isavuconazole, you may give it. If you don't have it, you may give it, and the patient is deteriorating and you feel you are very desperate, you may proceed for combination of antifungal, but you have certain drugs. There are certain drugs that are contraindicated to be given. For example, I cannot give two different azoles together. For example, I cannot give azole and liposomal amphotericin. I may be allowed to give liposomal amphotericin and caspofungin. I am allowed to give a voriconazole, but in certain voriconazole and the caspofungin, but in certain circumstances. So you may continue on the same line. You may consider adding if the patient general condition is deteriorating and you are sure it has been an aspergillosis. If you go for the guidelines for salvage, they are talking about liposomal amphotericin. They are talking about posaconazole. They are talking about combination, which I said it has a lot of debate whether to use combination antifungal or not to use combination antifungal. So, and if you go for this, these are the ECMED guidelines, recent ECMED. They are not recommending, for example, below the age of 2 years, if this is for the pediatric, to give a voriconazole. So below the age of 2 years, you're not allowed to give a voriconazole. And if the patient is less than 50 kilograms, you may give 9 milligram per kg, not as the usual dose, 6 and back to 4. No, it is just going to be 9 milligram, and you depend on the voriconazole level. And this is really very important because sometimes ردا على كلام الدكتورة سماح ان احنا بيبقى عندنا عيان ماشي على فوريكونازول وماشي على sub optimal level وتكتشف ان هو as if he's receiving nothing. So this patient should be modified according to the voriconazole level. The voriconazole was continued and the general condition of the patient was improving. And there was start of resolution of the nodules after 5 to 7 days from the last CT test. So he didn't add another antibiotic We didn't shift to a second line anti-aspergillosis and just wanted to talk about this patient that he improved on the single agent voriconazole. Dr. Samah, her comments are totally correct, but sometimes it depends also upon your clinical sense and the general condition of the patient and other findings and pattern of fever. So this should be put into consideration for such a patient. Should we antifungal be continued in spite of disappearance? Yes, of course. What do you think? Yes, it's a high-risk patient, should be continued at least for 3 to 6 months till resolution, and so long as he's receiving chemotherapy. These are the denoting that we should continue on even if the patient resolved on voriconazole, posaconazole, and even itraconazole. So if the patient has resolved and he's going to be put under follow-up, you may continue for even 2 to 3 months on antifungal therapy. So the patient was still on the voriconazole we were talking about, and suddenly he developed this lesion. So what do you think about this lesion? Would like anybody to comment? It's a case of acute myeloid leukemia. We have 2 similar conditions for this situation. It was one of them was an old case, and right now we're having another case. So, any comments? The patient was still on the voriconazole, and they have a progressive and infiltration MRI, as you can see, infiltrating the spine and infiltrating the thoracolumbar vertebrae. Progressive up to erosion of the underlying vertebrae. Shall we continue on the voriconazole? Shall we shift to another antifungal? Shall we proceed for surgery? What do you think, dear professors? Any comments? Surgery, I totally agree about this. A biopsy was done and it proved to be mucormycosis. So we're going to go back 2 weeks ago, starting from today. I was antifungal and breakthrough, and Professor Yusuf and another professor of infectious disease from Turkey is going to talk about it right now. We're talking about breakthrough fungemia. So sometimes you may be giving antifungal prophylactic, and the patient would develop another type of fungal infection. So this was the type of fungal infection. He was receiving antifungal and he developed a mucormycosis. Although the voriconazole is not the drug of choice at all for the mucor, but giving antifungal continuously is one of the causes of breakthrough fungemia. Before I talk about it, this is the mucormycosis, as you can see. And this article, I just wanted to mention this article. Those patients receiving prophylactic voriconazole are more prone to develop secondary mucormycosis. So if the patient is receiving voriconazole prophylactic, he is more prone. For example, a patient is not receiving prophylactic voriconazole and another patient is receiving prophylactic voriconazole. The patient receiving prophylactic voriconazole is more prone to develop mucormycosis. أوصل حاجة أحمد؟ قول. These are the factors favoring mucormycosis before you can diagnose. One of them is that the patient has the first one prior, as you can see, prior voriconazole or echinocandin use. So if the patient is receiving prophylactic, whether it's a type of breakthrough, whether they are more predisposed, we don't know, although it does not work. And one of the main problems is that the patient has, these are the predisposing factors. If the patient has hyperglycemia, and to some of our patients who did the serum ferritin, it was extremely elevated in our patient. If you proceed for serum ferritin, it's extremely elevated. So this would be highly put into consideration. So these are the predisposing factors. And if the patient has multiple CT chest nodules in more than 10, mostly it is related to mucor and unrelated to aspergillosis, and voriconazole sensitivity. These are the relative indications for surgery. As we said before, that if the patient has lesion for aspergillosis or mucor, if the patient has a lesion in the lung, or the patient has a lesion in the spine, or in the bones, or in the sinus. We have just done a case sinus by like intervention, not through surgery, but biopsy and curettage. It is very important. So surgery sometimes, if accessible, not total surgical resection, but you may proceed if the patient has a brain, space-occupying region of the brain, you may proceed for surgery. These are how to differentiate. These are the new ETSA guidelines, how to differentiate between the fungal infection, different types of fungal infection, if the nodules are multiple. And in the pulmonary mucormycosis, it is nodules, but hypodense sign, and reverse halo sign, which does not happen in the other one. So in the mucor, it's reverse halo sign, which is quite different than the other one. It is the halo sign. If the patient has monocytopenia and he has receiving steroids for more than 3 weeks, and hyperglycemia, and 3 weeks steroids is more prone. And these are the recommendation for the target. Surgery should be considered, antifungal should be considered, and a new guideline saying, which was published, that as you can see in number 2, although evaluation for disseminated disease, especially in the CNS, should be highly considered. So CNS examination and maybe CNS radiology should be highly considered for these patients. And these are the guidelines. We proceed for liposomal amphotericin. Number 1, and number 2, you may proceed for a combination of liposomal and caspofungal, or liposomal and eposaconazole. So if the patient, or in the new guidelines, you may proceed, you may raise the dose of liposomal amphotericin to 10 milligram per kg for the mucor. If not, the patient responding well, you start by dose of 3 to 5 milligram per kg. If the patient is deteriorating, you may add after a while posaconazole or a caspofungal. And if the patient is deteriorating and you feel very desperate, you may proceed for second, you may raise the dose of the liposomal amphotericin. These are the new guidelines saying that you may add isavuconazole at about 10 milligram per kg, and it has been recommendation number B, and A1 is liposomal amphotericin B. And as we mentioned before, the mixed, these are one of the indications if you have a confirmed mucormycosis that you may proceed for mixing 2 antifungal drugs together. We have talked about this. We have talked about that we may use iron chelating agents. You may try to raise the count, and you may raise the dose of liposomal amphotericin to 10 milligram per kg per patient. What is the total duration of therapy? Does anybody would like to add? The patient should be stabilized. The patient should be stabilized, and you may continue on the oral posaconazole after that for a long time, or you may continue on caspofungal after that. You may give it alone, or you may give the isavuconazole for a long time, and you may proceed for surgery, but you have to have marked improvement and disappearance of the lesion, either to be confirmed by radiological finding or to be confirmed by surgery and proved to be in necrotic tissue, and improvement of all manifestations. Shifted to liposomal, the fever resolved, improvement in the general condition. I'm going to talk 2 minutes about the third case. The third case is very rare, but I've seen this month 2 cases. That's why I started to talk about it. Is a case of acute myeloid leukemia on top of myelodysplastic syndrome. Started induction chemotherapy. He was receiving fluconazole as a prophylactic. He had a bone marrow shot acute myeloid leukemia, and he received high-dose cytarabine and idarubicin, and he has started to have a raised lesion in the chest and arms. This, what I'm going to talk about it now, is rare, but we are starting to see it nowadays, maybe because of the prolonged myelosuppression of the patient. So the patient bone marrow was free, antimicrobial therapy was started, fever 38, day 31 after the first course, bilateral pulmonary nodules, and he had cutaneous nodules in the abdomen, chest, head, upper arms and legs, and scattered petechia. Fluconazole was stopped as a prophylactic, and he started liposomal amphotericin B. The CT chest shows, as you can see, small nodules on both lung fields. Totally. ماشي خلاص بعد دي. And these are the skin lesions. So this is the differential diagnosis of the skin lesions: aspergillus, fusarium, and mucor. These are the differential diagnoses. So you cannot do, if you are suspecting fusarium, you cannot do investigation to confirm it. We don't have what's called the galacto, or it would not benefit. So biopsy is mandatory for such a patient. And it proved to be, I want to show you the picture of the patient. I don't know. I had it, but it seems it was missed. Yeah, that's it. This is the lesion, as you can see. Very non-specific. You may treat it as infection, general infection, or you may give him vancomycin. And this patient, surprisingly, proved to be fusarium. Biopsy proved to be disseminated fusarium, and he has lung lesions and skin lesions over his body, as you can see. And poor prognosis. The patient started treatment. Voriconazole is the drug of choice for this patient. And these are the SL guidelines from the year 2014 till the year 2020, saying that voriconazole is the first drug of choice. Posaconazole may be given. The second drug of choice is liposomal amphotericin. What I want to mention is, please consider breakthrough fungemia. Please consider that the skin lesion might be related to fungal infection. Not all of them is soft tissue infection related to soft tissue infection, and that's it. These are the guidelines, summary of recommendation, as we said. And thank you so much. Thanks to my dear Professor Dalia.
Thank you, Dr. Emad,
for participating with us and in this session, because her comments were extremely important in to know that the MDR is high in certain locations in Egypt, more than the international parameters, as you said before. Thank you so much.
Thank you, Dr. Emad, for this informative presentation. Thank you, Dr. Dalia.